Good afternoon, and thank you for allowing us to present our research here today. First off, coming off that last lecture, I want to say this is about mastery, not competence. Those are completely different things. Competence is what we all hoped we were when we graduated from residency, and what all my residents in the room should be striving to become, is just competent to do surgeries. Mastery is where we all want to be in the autumn and winter of our career, where you are now the expert who can see anything, they blink once, and then they take care of it. That definition is very elusive. We have it for individual procedures. That's the learning curve that we all know and love. We've all probably seen it for laparoscopic inguinal hernia repairs. That's just a generic one down there in the corner. We can't use that, though, for defining mastery totally of general surgery because there's too much variability in general surgery for that. Maybe you aren't in a practice where you're doing laparoscopic hernia repair, so it doesn't matter where you are on that learning curve. In 2017, there was a great article that was written talking more about how can we elucidate who is a master of general surgery. And they found 5 domains. And basically what these 5 domains do is they take you from meeting the patient, doing the history and physical exam, diagnosing whatever the problem is, deciding what surgery they need to do, being able to complete that surgery, recognizing potential errors and complications and doing things to prevent those, and then also rescuing the patient when those errors and complications do occur. Just based off of what I just said, you can see how cumbersome that would be to quantify all of those different things. A more simplistic view for mastery is the 10,000 hour rule. Now this was popularized in 2008 by the book Outliers by Malcolm Gladwell, and basically he looked at data that was done by Erickson in the 1990s. Erickson followed violinists who all started learning at pretty much age 5. There were no virtuosos at age 5. What he tries to point out in the book is there's nobody who's any better or worse when they get started. What makes the difference is that if you practice at least 10,000 hours, you become a master. So the difference they found as they followed these people is the amount of practice continued to increase for the people who became those virtuosos versus those people who just became good at violin and became violin teachers. In the book, he also discussed, for instance, for Seattle, it would be remiss to say not talking about Bill Gates, who coded for 10,000 hours before he started Microsoft because he had some extra abilities to do that. So it's that 10,000 hours that gets you there. I won't even talk about this much. This article is pretty much famous. The JAX article by Colonel Edwards in 2015, and that's what's kind of causing us to do this. You can see the case volumes there, but as has been talked about earlier, case volume is so difficult to say. If my 130 cases are lipomas, what does that mean for all of it? So our hypothesis, though, is that current garrison surgical care is unable to give you the adequate operative experience to reach that 10. The beauty of this S3, and we did this for a 5-year period, so a longer period than the 2015 article did. But you see surgeon, the number of the procedures, and then the most important thing, the incision time to the end of the procedure, which is quantified by the nurses. It doesn't have any surgeon variability. I can't say that, oh, I do a lap chole in 20 minutes. This is what actually happened. We left out any non-military general surgeons and any residents. Basically, we broke it down for the volume of cases that were being completed, and then we broke it down further by rank, and we used one-way ANOVA to compare our data. Here are the sites that participated, and thank you to those sites who did. We were able to include 122 general surgeons. We left off 20 because 14 of them were civilians, and 6 were general surgeons who were likely backfilling from their primary institution. This is why it was so important to have a point of contact who could tell you, oh, no, that person was actually a backfill at the time, so we could drop them off. But it left us with 102. Here's the Army-wide case volume based off of S3 for those institutions, and you see that the mean number of cases is significantly less than the 130 that was reported in the 2015 article. Here is it when you look at operative time, and when you do the math, it actually comes out to about 1 hour and 9 minutes per case that's completed. There's, of course, variability. You can see the wide standard deviation there, but it's about 1 hour and 9 minutes. When you break it down by rank, we majors, we carry the brunt of it. There's more of us, that's really all it is. But you can see a slight left skew when you're looking at the number of cases being completed. Lieutenant colonels are spread out a little bit more evenly, and then our 06s are all over the place, which is consistent with their jobs. Some are mostly focused on administration, and some are doing the surgery stuff. Here is it separated by operative time. Here is something where it's a little interesting is that the operative time for the lieutenant colonels goes up. We weren't caring about which surgeries were done, but you could hypothesize that because they're spending more time in the operating room as lieutenant colonels, they're probably doing more complex cases, which you would expect. Everybody I know wants to see this chart. If you're from one of those institutions, this is where we rank. Beaumont, congratulations. You had the most operative time per surgeon. So from this, then you can do some simple math. So about 950 cases are completed by Army General Surgery residents during their residency. At 1 hour, 9 minutes per case, you get about 1,100 hours worth of experience during your residency, which arguably could be a number that we used for assigning competence in the short term. Doing the math for the majors and lieutenant colonels, you see it here. What it comes out to is you would have to spend 53 years as an 06 doing their case volume to reach your 10,000 hours. This study definitely has some limitations. This is a convenience sample. I did not take every S3 data because we need those POCs. The data was collected from S3, so we only looked at primary surgeons. If it was a double scrub case, you could argue that that assistant surgeon gets experience from that. We did not include that. Endoscopy numbers is included in some S3 data at some of the, for instance, at WOMAC. We did our best to keep that off, but some of it could have snuck in as a limitation. Also, this is based off of calendar year. We don't really live off of calendar years because we work July to June. But because for convenience, we were able to do it by calendar year. So we do miss out on ETSs, PCSs, end of training, things like that. We did not include any deployment case volume and off-duty volume because we wanted to look solely at the garrison environment. And then these time estimates also don't include for our surgical subspecialists any time that was spent during fellowship. So, but our conclusion from this data is able to say that reaching the 10,000 hours of operative experience is impossible in our current model. To ask, because I know the first question is going to be, is this viable in the civilian model? Well, when you do use the ABS data, which is about 400 cases, and I've, granted it's anecdotal, and speaking to people that I've completed fellowships with, they all do about 400 cases per year at 1.1 hours per case, minus their 1,100 hours during their residency. It takes 20 years to reach the 10,000 hours. So if you finish your residency or fellowship at 32, it's about 52, 53. Who are the people that you see sitting up front at SAGES while they're here? It's the people in their late 40s, early 50s. So I think you could say that there is some credence to this data set. Not wanting to just be somebody who shares bad news without potential solutions, I think there are some that are out there. In 2015 Jack's paper, they brought up the civilian and military sharing agreements. I mean, nobody does this better than the United States Air Force out in Baltimore, as an example. That's not going to work for everybody. VA DoD sharing will work better for some other people. For instance, in Augusta, where I am, we have a VA that doesn't do a whole lot of surgical care. We could be taking all of that surgical care to get those numbers up. And then, if all else fails, we can always talk about expansion of off-duty employment. These are our POCs for each site, and thank you to them again. And then if anybody would like to participate who is not included in this, if we could leave this slide up for a couple of minutes. From the Army standpoint, we're just keeping it to Army right now. Please please think about emailing Dr. Plackett and participating. Thank you.